Okay, thank you everyone for joining us today with this special presentation. So we've been really fortunate to have Dr. Alex Lehn and Dr. David Palmer join us today to talk about their latest research. So both Alex and David are specialist FND neurologists working in functional neurological disorder and also doing research in functional neurological disorder. And the research that they're going to talk to us today is really important things that are happening in Australia in FND research. So, Alex, did you want to go first?
Sure, I start, yeah.
Thanks so much.
No worries. Well, thanks so much, everybody, for giving up your weekends and joining us today. So David and I have just put a few slides together, probably in total 50 minutes or so of talking time. So I probably do half an hour, and David will do 20 minutes about a few other projects. And then hopefully we have some time for questions afterwards as well. And with questions as well, like, don't be shy, like, grill us, hit us hard. If there's things we don't know, we also tell you we don't know. So you won't get any bullshit from anything there either. And when I put the slides together, I realized there's actually quite a few projects we are working on. So I needed to cull them a bit. So I left a few out. So if you ever have us back in the future, I can talk you through a few other projects as well. And a few literally just have a slide or two, so you see what's going on. And a few I thought might be of more relevance for you and where we are a bit further with the projects. I'll give you a bit more detail about that. Yeah, so I'll talk about half an hour. In between, if there's burning things that don't make sense or so, or that you need some clarification, I'm very happy to be interrupted during the talk as well. So don't be shy with that either. So I did through a few different sections. One is about epidemiology, where we wanted to understand a bit more. And one area particularly we were interested in is the connection of FND and women's health, which David and I have been fascinated for many years. And when you start looking into that, it's really weird. There's some areas in FND where it's literally no, although it's so common, such a big issue, no research done, like, at all. And when we see people with FND, not everybody, but a lot of women we see report very commonly problems with changes with FND symptoms according to the menstrual cycle, changes of FND symptoms when they go in menopause, changes with FND symptoms around pregnancy. And so far, we have no data about that at all. So David will talk you through a project we've done particularly about FND in women's health, and I'll talk you through a project we've done particularly with looking at FND and pregnancy. And that's something not only the two of us, we work with a really fantastic group of experts in neurology and obstetrics and women's health in other parts of the world, maybe in the UK. And we're just about ready to publish the pregnancy study. So hopefully that's something you can actually see in print in the very near future as well. So what we've done for the pregnancy one is, so we've done one kind of survey around that, particularly, so this is all anonymous, with women who are kind enough to participate and give us their information across the world. So very Australia heavy, thank God. Thanks, guys. You've done a lot of work with that, but this is really across the world. And in total, we had 111 women who participated in that study with kind of typical numbers as you would expect. So mean age was 37 years, mean duration since diagnosis was 4.5 years. So kind of quite average number of distributions that we saw there. And there's a few questions we certainly had, and I'm sure you have as well, like, what happens with FND during pregnancy? Do symptoms get worse? Do symptoms get better? Are there particular things that make them worse or better? They might have, other health issues, other typical pregnancy-related issues like hyperemesis, or pain issues, or other concerns that might contribute to worsening or improving of symptoms. And then, of course, the real concern is, can women actually have the kind of births they want to have, or other issues with that? Or if they do have the births they have, does that cause problems? So that's something we've been very much interested in. We also wanted to see how well supported are women during their pregnancy, how much knowledge do their health professionals who look after them have about FND and related conditions. And there's a few particular areas that often come up amongst health professionals, and I'm sure amongst women as well. Like, if you have an epidural, could that trigger of FND? Could that worsen FND? If you have a Caesar, or if you have instrumentation with your vaginal deliveries, could that cause problems? So those are the kind of issues we've been looking at. And there's a few I thought really helpful bits of data that came out of the study. So one was, this is actually a graph David put together, where we looked overall. So of course, this is group level. So you see individuals, some of them might have worsened, some of them might have improved. But if you look at overall, the average of the 111 women, actually overall FND symptoms did not change across pregnancy. So I guess bad news is they don't necessarily get better either, but they don't worsen overall if you look at the group level either during pregnancy and in the early postpartum period. So we thought that was interesting. When we quizzed people about their treating health professionals, I guess with that, that's probably the kind of answers I would have expected. So on the left side, you see we asked women about how knowledgeable they thought their treating health professionals were about FND. And expectedly, you could, what they reported was that amongst midwives and their GPs and obstetricians, many of them didn't have good knowledge about FND, which is what expected. And that overall was reportedly better, particularly amongst the neurologists and to a lesser degree, so amongst the psychiatrists. On the support level, on the other hand, that was flipped around a bit. So we also asked women how well did they feel supported by their health professionals. And that's something where clearly the neurologists in particular didn't come across all that well. So many of them actually, many of the women we quizzed did not feel well supported by their neurologists and to a lesser degree by psychiatrists, but felt actually quite well supported by their midwives, obstetricians, and GPs. So that was good to know, and I guess just showed us still what we need to work on, particularly education amongst health professionals, and that's a recurring theme. We certainly had in free text responses from our participants there as well. So just, I guess, cut to the chase directly, and I'll just give you 2 slides about what I think are some of the real key findings of that study. So one is, as I mentioned beforehand, that at least at a group level, we actually didn't find changes to FND symptoms in regards to their severity during pregnancy. And I thought that was really reassuring. What was good as well to see that the rate of pregnancy-related complications overall in that group actually wasn't much different compared to the general population. So that's things like nausea and vomiting, that's things like symphysis pubis dysfunction, the common things we see in pregnancy, yes, occur in FND patients, of course they do, but actually not significantly more common than you would expect it in other patient groups. So that's, I thought, reassuring as well. What was really nice to hear as well, the vast majority of women reported some issues, some problems with lack of knowledge about FND, but the vast majority of women actually could have the birth they wanted. And that was something I think was really reassuring to see. And the last point, I think, again, was particularly positive to hear about. Yes, of course, understandably, many women worry about the ability to care for their babies and their ability to breastfeed because of the FND. But actually, more than 3/4 of patients said, despite the FND symptoms ongoing, it actually didn't stop them being able to care for their babies, and it didn't stop them being able to breastfeed. So that was, I thought, really reassuring and positive as well. Clearly, what we saw with that, and I showed you one of those slides before, and there are significant gaps in knowledge and clinical guidance. And that's something David and I see on a very, very regular basis. You kind of think, so I work at Mater Hospital as well in Brisbane, where lots of babies get born. And still several times a year, we get phone calls from obstetricians with in high distress. Oh, I've got this patient with FND, don't know what to do. You kind of think we slowly get better with it, but there's still a lot of work we have to do. And clearly education is something we have to work on that. And just one other point I wanted to put in beforehand, I didn't have time to show you those slides. So yes, epidurals, we saw overall a very small but significant increase in triggering of symptoms and worsened symptoms after having done epidurals. Very small, but it was there. We didn't see any changes after cesarean, so it's either emergency or planned Caesar. But we saw in patients with vaginal deliveries who have instrumentation, we saw some worsening of symptoms in those patient groups as well. Small, but epidurals and instrumentation appeared to trigger off or worsen symptoms or contribute to worsening of symptoms, at least in some women that participated. So we thought that was interesting. The FND and women's study that we did kind of in parallel as well, David will talk you through in a few minutes. So I'll just mention a few other projects we're currently working on quite quickly, and then I'll spend a bit more time on FND and driving, which we've done some research on as well, which I think is of particular interest for all of us. So one study we're working on at the moment is the rate of FND in Aboriginal and Torres Strait Islander people. Again, at the moment, literally zero, not a single study, anything done about it, which I think is such a crying shame, because there clearly is an issue. This is a disadvantaged patient group of people for many, many reasons. And clearly, many of those risk factors we see in contributing to FND, mental health disturbances, trauma, many of those kind of issues are more common in the ETSI population compared to the general population. So we need to get some data around that and need to understand a bit more. Do patients in this patient group, do people in this patient group get FND? Do they get similar presentations? Can we address those differently? Do we have to change our approaches to diagnosis in those patients? Do we have to change our approaches to treatment in those patients? So we need to get started, some numbers behind that. So what we realized when we looked into that further, it's actually really hard to capture for many, many reasons. So what we thought, just as a kind of simple project to get us started, we do a retrospective study of all the presentations to our emergency department at PA Hospital for the period of 1 year. So as you can imagine, lots of presentations to go through, but we wanted to get a really good representative sample of that. So we looked at that in patients who present of the Aboriginal and Torres Strait Islander people versus non-ETSI people, and just want to see, do they present with same rates of FND? Do they present with similar symptoms, to get us started with that? So we have more than 1,000 presentations we've gone through so far, and we're counting, and hopefully at something late in the year we can present some more data around it to you all. And just very quickly as well, another project David is working on with one of our old residents is FND and stroke mimics. That's something we've thought again was particularly interesting. Obviously, strokes are a massive issue, devastating for people when they have strokes. But what we saw, and what's kind of shown across the world as well, a lot of patients who present as strokes or possible strokes actually don't have, as in blood clot strokes. They actually have other causes for the presentations. And across the world, about 10% of patients who present with what is initially thought to be a stroke are actually because of FND. And we think there's sort of real relevance because, first of all, picking those patients up and giving them appropriate treatment is really important. But also the treatments we do give for people with possible strokes are not without risks either. So you might be aware, often for people with strokes, we give them clot busting medication to kind of get rid of the clot that causes the issues. And this is really powerful stuff, but can also have powerful side effects. So, for example, there's one bit of data where nearly 2% of patients who are given those medications actually die because of those, as a side effect of those treatments. So these are not irrelevant. And there is some data there already about stroke outcomes, or outcomes of stroke mimics, and short-term patients with functional stroke mimics seem to be doing really well. So they often recover quite well in the short term, but there's actually very, very little long-term data. And that's something we thought we'd be really keen to learn more about. So can we pick those up? And then particularly, of course, of relevance, can we do something more about that in the future to improve long-term outcomes? So we wanted to look at, do patients with stroke mimics come back with other stroke mimics or other functional symptoms? What are factors that might contribute to that? What are factors that predict those kind of things? And is there something we can influence that? So we're actually quite far with that already. So the data collection is all done, and David and Liam are working on the stats on that at the moment. So again, that's hopefully something you'll see very soon. And maybe I'll present to you, or David will present to you late in the year with a bit more detail. So a bit more time I want to spend on FND and driving, which for health professionals, it gets people very, very tense when they talk about it. And I'm sure an issue for many of you in the audience as well. And I hope you can cope with that. Actually, the second study I will present to you was for us really surprising in terms of findings, and probably some of the findings you guys are not going to be terribly happy to hear about. But look, that's research. It is what it is. So I'll talk you through the steps we have made with that. So you might well be aware, we have in Australia reasonably strict driving restrictions for various disorders. And they're not just plucked out of hot air, because I used to think, oh, they just put some random numbers in there. But actually the National Transport Commission, they put a lot of effort into how they calculate a certain risk for people to drive. And of course, that's a balanced call, because people's liberty is important, particularly in Australia, particularly rurally, and in regards to quality of life. But of course, we need to be safe for the public as well. And so to give you an example, for the guidelines we have currently for epileptic seizures and alcohol intake that you might be aware of, generally what's accepted in Australia is double the risk of the normal population to cause a car accident. So the alcohol rules we have with 0.05 alcohol level, roughly on average, at that alcohol level, you have double the risk of a normal population to cause an accident. So that's generally the cutoff we have. And same with epileptic seizures, with a half a year or 1 year cutoffs we have, is roughly double the risk. So that's how those calculations are done for driving, certainly in our country. And so we have guidelines for that. And we now, as of a few years ago, have guidelines for functional seizures as well. I do apologize. I was battling hard against that. In the driving guidelines, they're still called PNES, so psychogenic non-epileptic seizures. I really tried to get rid of that term, but they wouldn't let me. So at the moment, we're still stuck with that term. But the current guidelines are, if people are not sure if the events that patients have are because of FND or epileptic seizures, basically it's the same guidelines that are for epileptic seizures. And for that, the default non-driving is 12 months. For first seizure, minimum is 6 months. For people with functional seizures, the default at the moment is 3 months no driving. So that's the current guidelines for that. But they're very much just based on kind of expert opinion. There's not much data behind those because the data wasn't available yet. So we thought, okay, we should look into that a bit more and see if we can actually get some numbers behind it to just have a bit more meat behind it, so we can see if we're doing the right thing with our own guidelines. So the first study we've done about that was a study with the hazard perception test. And I'm not sure, some of you might be young enough to have done a hazard perception test. Some of you might not be young. I haven't done one. I'm probably too old for that. But in most states in Australia, the hazard perception test is nowadays part. I think when you go from the P license to a full license, you have to pass the hazard perception test. And it's a really well validated test that is kind of very closely linked to driving ability and to crash risk. And so it's across a number of different diseases and disorders, really well validated test that's done for that. And I'll just show you a video of that, how it looks like. So there are really two parts to that. So the first part is the hazard perception test. And the second part is a hazard prediction test. And the way the hazard perception tests work, literally they put you in front of a computer and show you those kind of videos. And then you basically need to pick if there's any trouble that's coming towards you. So there might be here, for example, the car on the left that's coming in. There might be a little kid that's playing with, you can see that fast car coming in there. And that's something you need to be able to click then and say, oh, here car coming from the left, here child playing with the ball, and the ball's running onto the road. So that's a hazard perception test. And then the hazard prediction test is basically a similar thing, but then all of a sudden the screen goes black and you need to be able to recognize, oh, okay, I can predict, I could see that car coming from the right, that might be an issue. I could see those children up in the front, that might be an issue. I could see the car in front of me braking all of a sudden, that might be an issue. And you actually have to predict trouble with that. And so we did that hazard perception test with 43 FND patients versus 43 healthy controls. And we were really excited about the results with that. So overall, FND patients actually have done incredibly well with that. So in the hazard perception part, we actually couldn't see a difference at all between the performance of FND patients and patients without FND. And in the hazard prediction test, FND patients actually did better than normal, than healthy controls in their test. So we thought it was actually really exciting. And there's some other stats we did with that might be of interest for you as well, because you kind of think, oh, maybe if people have symptoms for a long time, they might do worse. Or if you, for example, ask someone with functional seizures, like how long it's been since you last flare or last attack might play a role. Actually, none of those things played a role in the performance of patients. So we thought that was really exciting to see how well patients have done in their test. So then we thought, oh, that's kind of cool to see how they do with that. But of course, the real money is, how do people do in real life? And that's much, much harder to measure. So we did anonymous semi-structured interviews in 30 FND patients about the FND symptoms, about the experiences, about the challenges they might have in everyday driving. And we really just wanted to find out kind of what do they struggle with, how do they manage their symptoms when they have them, what's their driving patterns, and have they had crashes and had their trouble with that in the past. And I have to say, there was a real eye-opener with many results that I guess now make sense for me, but at the time I didn't really expect. So one was about driving difficulty. They're probably not unexpected that all patients, actually all patients, reported that driving in a car provoked FND symptoms and did affect, and FND did affect their driving abilities. So that's something I guess we would expect. About 3/4 of patients reported worsening fatigue with driving. Again, that's something we expect. And about 2/3 of patients said that FND impacted their perceptual cognitive abilities when driving. And again, that's all things we probably would expect. That was a real eye-opener for me about crashes, because I must say, even someone who works so much in this field, I kind of had this, don't know, this perception that, or at the end of the day, the brain still kicks in and people can control things. But 81% of people that we interviewed mentioned that at least one crash or near crash in the past, and 19% had a crash or near crash after the onset of their FND symptoms, and 60% of those, at least they might be wrong as well, but said they actually thought their crashes were related to the FND. And that's something I must say I didn't expect, and that was a real eye-opener for me. And I just put a few quotes in there from the free text responses. I think they were quite telling for you as well. So the participants that we had. One participant said, I was driving myself and I think it was with 3 work colleagues back from a work event. I was approaching the lights and the light was orange and I was trying to brake and my leg wasn't responding. I had no choice but to go through the orange light. Thankfully, it was safe to do so. And another said, I wanted someone to drive the car for me, but it was a manual and none of the other passengers could drive manual. I just had to do my right hand on my right leg, and every time I needed to brake, I would just slap it or I would lift it and we got back. And again, an interesting one about the ability to judge their own safety. That's from a patient who has had severe symptoms in the past, but improved more recently, who said, I have to say I don't know, but that's with hindsight. At the time, I would have told you categorically, I know when I can and I know when I can't. But as I think of that now, I have to say, I really don't know. So just to summarize that, things that we saw was flares of pain, difficulty with attention and reaction time were commonly reported issue. Lots of participants said, particularly during stressful driving situations, they had issues, and particularly when being sensory overloaded. The high rate of crashes is something that really surprised me. But of course, as you would expect with FND, it's so variable, it's so complex. There's so many factors that play a role. I find it's really difficult, but in many ways now, I find it more difficult for me to judge about driving safety than I was before we did those studies. But I have to say, myself and clearly many of us others have probably underestimated the risk of driving with FND. And I think that showed me that we need to come up with better, more bearable, more sensible guidelines about driving in the future. Then a few slides I wanted to talk about treatment, and then I'll show you at the end just 2 slides about a project we're just about to start as well that I think is really exciting. So that's a study we've finished, and we've just done the stats of that last. Hopefully, again, you'll see written up over next few months. So we looked at patients with triple PD, and if you haven't heard of triple PD, that's what people used to call chronic subjective dizziness, and it stands now for, I hope I can still say it, persistent postural perceptual dizziness. It's the new term we use for that in the last few years. Really nasty functional disorder, like it can be so disabling. And in terms of treatment at the moment, generally the most accepted treatment for that is vestibular-based rehabilitation, which for some people can really make a difference. Sadly, for some patients, outcomes are still bad with that. And we thought, well, maybe there's other ways we can come up with to help with that. And particularly what we thought about, are there ways we can actually come up with treatment approaches where people don't have to be at a fancy vestibular rehabilitation center, but hopefully there are things they can do at home, or they can do with their more general physiotherapist in areas where they don't have specialist input. So what we developed for that was basically a VR goggle app with desensitizing graded exposure therapy. So the way they work for the VR goggles, so people put the goggles on, and there's basically, it's like a game, different levels of, where in the first level, it's all just black, and they just need to be able to focus, just move their eyes onto an object for a few seconds, and then the object goes away. And then as levels get higher and higher, for higher levels, they have to move the head a bit to the certain object, and then goes away, and so on and so on. And then you can see that's an example of a higher level when they basically, we sensory overload them more and more. They're kind of driving in the car, and they see kind of birds singing and trees going past, and they really have to turn their heads more to look at certain objects. And the idea with that is to desensitize the system more and more, to help with retraining the brain and treating symptoms. So we did this as a randomized prospective trial, and we had 20 patients in each group. One patient got expert vestibular rehabilitation, and the other group got expert vestibular rehabilitation as well. But on top of that, actually got the VR app and got that home with them, and at home got homework how to work with that, and did that kind of in parallel to their vestibular rehab. And so we had measures that we did in clinic objectively, like gait measures, stride length, velocity of gait, balance measurements, but also participants gave us their subjective reports, how they felt, how the dizziness felt, and how they did in everyday life. And we just had a look at the stats a few days ago, and the stats look amazing, like really cool, really reassuring outcomes. And something relatively simple like that, I hope that it's something, first of all, really has new innovative approaches to treatment, but hopefully for you guys as patients out there, something of hope that there's actually new treatments that can make a real difference for patients. So just on the stats now, hopefully Dasha, our head physio, will be able to write it up over the next few, month or two, and you'll see the full data of that coming out later in the year. Just the last few slides, I wanted to talk you through a project we just about to start looking into underlying mechanisms. And I think that's super, super cool. I'm really excited about that. And that's a small grant we got from our research support network at Metro South about FND and the gut microbiome. And I think it's super, super cool. As you might know, the gut microbiome is a hot topic in many areas at the moment. We didn't think in the past that the gut and the brain are connected. Turns out they're very, very much connected. And so gut microbiome is the type of bacteria that you have in your gut and the distribution thereof. And turns out there's a lot of data in a whole number of different disorders that shows abnormalities in that. So for example, we do another project at the moment for Parkinson's disease. There is a wealth of evidence looking at changes and abnormalities in the gut microbiome in a lot of disorders that are connected and are risk factors for the development of FND. For example, anxiety, depression, PTSD, autism have a ton of data coming out to show that there are abnormalities in the gut microbiome and potentially treatment approaches through the gut microbiome with that. So we thought that super interesting. At the moment, again, as you would expect, zero data about FND on that. So we think we need to look into that further. So we got a project grant for that. So at least for 50 patients and 50 age and gender matched controls, we can look into that. So what we do with that, if people are happy to give us a bit of their blood and a bit of their poo, we will do high resolution sequencing of participants' gut microbiome, and hopefully we can actually start seeing a signal of healthy controls versus FND patients. And we actually, in the poo and in the blood, we look at any signs of inflammatory processes and inflammatory markers, which again, we think is super interesting. Probably not for everybody, but inflammation, I think, does play a role in that. And we would be very hopeful to see if that's an abnormality we can find, and hopefully then new treatment approaches of that in the future. So that's a grant which has got, we're just working on the protocol, and we haven't even done the ethics application for that yet, but hopefully that's a study we'll be able to start later in the year, and hopefully I'll be able to give you some exciting results about it. But what I do hope for you guys now, that should give all of us hope. We're not standing still. We're working on stuff. Some of those might be dead ends. Of course, that's how research is like. But I think it's nice to see that the world is not standing still and we're progressing in the right direction. If those projects or other projects or any of the research in FND, in the FND field, tickle you and you're keen to be interested in that, David will talk about that a bit more afterwards. But I guess part of the reason why David and I are here is we guys need to connect. We need to work together in that. So be really keen for as many of you as possible to sign up to the FND Research Network. That's the link in there. We do need healthy controls as well. So for example, for that gut study, we need healthy controls as well. So if there are people amongst you who don't suffer from FND, join as well. If you do suffer from FND and have partners, friends, or whoever who are keen to help as well, get them to sign up as well, because we need healthy controls for those studies as well. And with that, I'll wrap up. I promised half an hour. I think I'm just about on time, and I'll hand over to David.
Yeah, that's wonderful. Thanks so much. We'll go straight into David before we do the questions, and we'll do the questions at the end. Thanks, David. Are you able to share your screen?
Yeah, I'm just popping them up now.
Wonderful, thank you. And I've shared that research link in our chats, and I'll also share it in the group and when we share the video.
Right, hopefully you've got slides there now.
Yep, it's working well, thanks.
Well, yeah, before I start, I actually wanted to acknowledge Alex. So the reason I'm in Australia is I came to work with Alex, and it's probably, I'm a bit lucky that I am, because in the job interview I had with Alex, I put my foot in my mouth and said that I wasn't interested in research. And then he told me that half the job was going to be research. And you'll probably see from this talk that he's really changed my mind on that. And now I'm actually doing more research than clinical work. So like Alex and with Alex, I've got quite a few things on the go. I've chosen to speak mostly about three as kind of the big things that we're doing at the moment. I'm going to gloss over some of the rest at the end, but I'm very happy to take questions on those if we've got time at the end. So the first thing I'm going to go through is some preliminary results from the sister study to the pregnancy study that Alex presented. So rather than pregnancy, this is looking at the effect of what menstrual cycles, menopause, women's health problems, all these things have on symptoms of FND. And I think we've got some really cool results from that I'm just starting writing up at the moment. And then we're going to talk about what's sort of my main focus at the moment, which is looking at the brain mechanisms that might be the cause of FND. And finally, I'm going to tell you a bit more about FND Research Connect, which is the website that Alex has just mentioned and Kate's put in the chat. So this is the big question that we're trying to answer with the women's health study. So what does the menstrual cycle and women's health symptoms do to symptoms of FND? Sometimes people phrase this as what do the hormones do? I think that that's a natural second question, but I think that we should see this just as what the experiences of those things do before we decide whether it's the hormones or something else about what happens there. So this is one of the two projects that Alex and I have been collaborating on for the longest time. When I arrived in Australia, my plane landed and I went straight to Alex's house. He bundled me in the car to take me to a talk that he was doing. And on the way, he told me this great idea he had for a study of what women's health did to people with FND. And so here we are 3 years later, finally going through the results, and I think with some quite cool results. So this was an online study like the other one, because every woman with FND has been a woman with FND, but not all of them have been pregnant with FND. We got a lot more responses. So we've got just under 550 responses to this survey. We asked a lot of things, as you'd imagine, and I think probably some of you did the survey, but I'm just going to take you through some of the headline results. So this chart here is looking at how women in the survey perceive their symptoms of FND across the menstrual cycle. The labels are a bit medical at the bottom. So the follicular phase is the sort of the first half of the month until someone ovulates. The luteal phase is the phase from when ovulation happens to when the period comes. And we divide those up because what the hormones are doing is quite different in those two phases. Premenstrual phase we define as the 2, 3, or 4 days before the period starts, and menstrual is while the period's happening. And so you can see pretty clearly here, blue is good, symptoms are better than average, red is worse than average, and grey is the same as average. You can see that overall, the group thought that things were much worse in the lead up to their period and around their period, but also that they were probably worse in the second half of the cycle rather than the first. But the nice thing about having a lot of data is that you can do a lot with it. So we went on and we used quite a cool statistical technique where you can take big data like this and ask the statistics to pull out subgroups from it and say, rather than calling this one big lump, can we say there are 3, 4, 5 groups who look like each other more than they look like the whole group? And when we did that, this is what we found. So it told us that it looks like there are probably 3 subgroups that look different from each other. Here, they're just called cluster 0, cluster 1, and cluster 3, although we can speculate more about what might be happening in these groups. And you can see that they are quite different. Cluster 0 really doesn't change much across the cycle. Maybe things get a bit worse in the lead up to the period and when they've got their period, but overall, most people are saying that things are about average most of the time. Cluster 1 is very different. So during most of the time when they don't have their period, they look just like cluster 0. So mostly things are about average. But then in the lead up to their period and through their period, things get bad. So their symptoms, all of them say, get worse in the lead up to the period and then stay bad through till the end of the period. And then cluster 2 is different again. So these people all say that their symptoms were the same or better in the follicular phase, so the first couple of weeks after they have a period. Then they ovulate, which they may or may not feel, but their hormones change. And in the luteal phase, that second couple of weeks, their symptoms all get worse. In the premenstrual phase, they get worse still. So the dark red here is people saying their symptoms are much worse than average, and people are really endorsing that strongly. And then when their period starts, things improve a lot. So more of them say they're worse than average than better, but it's nothing like it was in the lead up to the period. And so these we can say are different groups. And the last things that we're trying to pull out of the data is to say what's different about these groups and why might this happen. What I speculate, and the data is starting to show, is that cluster 0, this is the biggest group. This is probably what happens to most people, and that their period doesn't affect them very much. Cluster 2, I think, is the one that has the next readiest explanation. There's a condition called premenstrual dysphoric disorder, which is probably underdiagnosed in the general population. And this is where a condition where in the lead up to their period, women get symptoms of feeling down, anxious, lacking energy, generally feeling yuck. And this is really sort of marked by the fact that the symptoms come on mostly in the few days leading up to the period. But then when the period starts, that the symptoms improve. And this is what we're seeing in cluster 2. So from the luteal phase, that second couple of weeks, things are starting to build. They're really bad as the period's coming. And they let up as soon as the period starts, and then things are good. You know, they're better than they were in the last couple of weeks after the period finishes. So we collected a lot of data to be able to estimate whether people had premenstrual dysphoric disorder, whether or not they've been diagnosed. And that, like much more of the group that are in cluster 2 scored high in that score than any of the other groups. So that seems to line up as probably what's happening there. And that, I think, is really exciting because there's a lot of treatments for premenstrual dysphoric disorder. And that means that if we can identify this subgroup where PMDD is the thing that makes their symptoms bad for a good portion of the month, if we treat that, their FND might not go away, but their FND will hopefully be, on average, a lot better. The last group here is cluster 1, and this is the one I'm still doing the analysis on more than the others. But what I think is the case here is that this is people who have particularly bad periods. So people who have a lot of pain, sort of troublesome bleeding, and just generally a lot of period symptoms. When that happens, we know almost any symptom tends to flare up FND, and it wouldn't be surprising that that flares it up both when the period's there and as the period's approaching, whether that's from the symptoms or the anticipation that you're going to have this really rough few days. So the data is sort of lining up towards that. That's the one I can least confidently tell you about so far, but I think that that's what we're going to see as the driver for that. And that also, I guess, suggests a treatment. You know, gynecologists have a lot of ways of dealing with problematic periods, whatever the symptom is. And this might give us some data that we can sort of wave at people and say, look, for people who have FND, really you should go hard on this because you can take away this awful period where not only are they suffering from period symptoms, but their FND symptoms are that much worse. So there's a lot of other data from that study. I'm happy to take questions on that. You know, we asked about menopause, we asked about breastfeeding, we asked about a lot of health problems that happen to women. But I think that those are the biggest findings we've got from it. The next thing I'm going to talk about is really what takes most of my time at the moment, and that's trying to better understand what the brain mechanisms of FND are, and in particular, what the differences in brains between people who get FND and people who don't get FND is. So I'm going to start here by leading you through sort of a light version of the theory I'm working on testing here, because it's a little bit of a departure from the way that we often think about FND. So these are sort of, I think, the key ideas. So the first is that functional neurological symptoms aren't what FND is. Functional neurological symptoms happen commonly in people who will never get FND. I know in my life, I've had functional symptoms and I don't have FND. In neurology clinic, it's common for neurologists to see people with symptoms that are functional symptoms, but where they're not quite FND, you know, they're not bad enough, or they're getting better on their own quite quickly. And neurologists tend not to diagnose these people with FND. And on the whole, these people mostly don't go on to get FND. So that's another place that we see this. The other place that it's not called functional symptoms, but it's really obvious, is in sports people. So one of the defining things that makes a neurologist able to say that something is a functional symptom rather than a different neurological symptom is what happens when people pay attention to it or when they try to overcome it. So if I think of functional motor symptoms, almost always people tell me that the harder they try to overcome it, the worse it gets. You know, if you have a weak leg and you try harder to move it when you have FND, it will just do what it's told even less. Whereas if someone has a weak leg from a stroke, often they can eke a little bit more out when they try harder. So that's very distinctive. The place we see this happening quite commonly on TV is in sports. So we see it happening very briefly when people choke. You know, the rugby player who goes for a kick, gets stuck in their head, or concentrates too much on getting the kick right rather than letting the automatic kick they've practiced 1,000 times happen, suddenly muffs a kick. We also see it lasting longer. And I think in the last year, the best example of this has been Simone Biles. So Simone Biles, the Olympic gymnast, quite famously had to withdraw from the previous Olympics due to something that gymnasts call the twisties. But after that, there was a lot of media interest. And when you look at how gymnasts describe the twisties, they describe it exactly the same way that people in FND clinic describe functional motor symptoms to me. They talk about something that used to just automatically happen, that now, in the moment they're spinning through the air, their attention comes to, and they're trying to figure out how to land or where to put their hands or their feet. And that then makes the movement not work right. So we can see this evidence that functional symptoms are all around us, yet FND is not all around us. And so this, I think, leads us to the conclusion that we should actually think about FND differently to how we do. At the moment, most people think of FND as the condition where people have functional neurological symptoms, and that the difference between people who have FND and people who don't is that they get functional neurological symptoms. I think we need to change that. I think that when we think of what FND is, we need to think of it as some people's brains being more able to resolve functional symptoms when they happen than other people's brains. On the handful of times that I can think of things that have been functional symptoms I've had, they've lasted seconds, minutes, they've been mild, and then for whatever reason, my brain has been able to get rid of them. If it hadn't, conceivably, they would have kept getting worse and worse, and then I would have had FND. So I think we need to be looking for this difference and saying, how do functional symptoms get better? And why can some people's brains get rid of functional symptoms, but others can't? And that leads me on to the theory that I'm testing at the moment. I'm going to talk about this quite superficially because it goes quite deep into brain science, but again, ask any questions you'd like at the end. So our brains don't do what it feels like it is to have a brain. If I think of what my senses are doing and what it feels like to have a brain and senses, it feels as though information just comes to me. It feels as though when I'm looking at the screen that you're on, that the light from the screen comes to my eyes, it fires off some electrical signals, and those signals get processed more and more until at some point they're perception, and they're what I see of all of you in front of me. That actually, no matter how much it feels like it, is not what the brain does though, and it does almost the opposite. So it starts with perception. So my brain, because it saw it a moment ago, expects that when I look at the screen, I'll still be seeing all of you there. And then that it takes the information coming to that level of processing from the level below it and says, is what I expected about right? And if it was about right, then it sort of sticks with what it had. If it wasn't about right, then it updates based on that new information it's had. And that kind of goes all the way down the hierarchy of how the brain processes until it's just using that information to update what it expects will happen. This happens in every single thing the brain does, as far as we know. And there's a way in which a very small difference in how the brain updates these expectations between people might account for the difference in susceptibility to FND that we see between people. This is the kind of thing that probably wouldn't be noticeable in everyday life, but would have some small and measurable consequences that we should be able to measure experimentally, and also means that when a functional symptom happens, the brain might be just slightly less able to get rid of it, and the symptom will then have more chance of getting stuck and becoming FND. So I've gone out to test this theory a number of ways, and the theory I'm actually in the process of writing up to publish as an idea at the moment so that other people can start testing it. But the first thing is to test this underlying assumption that everyone gets functional symptoms, because if it's wrong, and if I'm just getting functional symptoms and misinterpreting what Simone Biles has, then this theory stands on nothing. And so to test this, I went and asked people if they had functional symptoms, but you can't just go and ask people at the mall because people don't know what functional symptoms are. And so I did this at the International FND conference last year. I ran a survey there that had some questions that were worded as closely as possible so that they would only turn up functional symptoms and not other funny things people had had. And I gave it to people at the conference with the assumption that people there are experts on functional symptoms and should be able, when they think of these things, to figure out what they experienced. So I got just under 100 people respond to it. And these are the results we saw. So just under 40 people had had functional sensory symptoms. Just over 20% of people had had functional motor symptoms. And just under 50% could remember having a functional motor or a functional sensory symptom. So these things are often mild, and I would expect people to forget most of them that happen to them. And so I think that we should assume that this is an underestimate, but that at least 50% of people have experienced functional symptoms in their life. This other group, dissociation, is a symptom that many of you may have had. It often happens around dissociative attacks or functional seizures. But it can happen for other reasons, and it can also happen on its own. I asked about it as sort of a proxy for whether people might have had things that were in the spectrum of a functional seizure without having a functional seizure. And if you include that, then the number of people who have had any functional symptom goes up to about 57%. But I'm not including it in this main number because it's a little bit less certain whether that's the exact same as the functional symptom people get or not. So this makes me confident to carry on, to say that functional symptoms are normal, and what we need to be looking at is why some brains get rid of functional symptoms when others don't. This, I forgot I put this slide in. This is just some more data on what these symptoms look like. So I would concentrate here on the coloured bits. These are the probability of giving that answer or a less severe answer. So for duration, most people, they were gone within about a few minutes. And for only a small number of people, they went out to weeks or months. Most people who had had these had multiple occurrences. And most people who had had them, we can tell they were mild because they had next to no effect on their function. So being able to work, being able to socialize, being able to go to school. So now on to the next thing. And this is about how I'm trying to test this brain updating difference that I think may underlie what's happening here. So this screen may be familiar to some of you. I see some names I've met doing this, and it may cause some of you PTSD. But at the moment, I'm running these two experiments that I sort of describe as being a bit like boring computer games that, because of the way they're put together, mean that people need to update their expectation of what's happening next in a specific way. I'm telling you in general what happens, but not the exact specifics of this because the experiment's still running and I don't want to tell you too much about what I'm looking for in it in case anyone listening to this is going to come and do it. But hopefully the next time I speak, I'll be able to describe it in much more depth. So the first one is this coin catching task. So people sit and they're looking at a computer screen that's got this picture of a lake you see on it. And they're told that someone that they can't see standing somewhere behind them is throwing coins into the lake. And each time they do this, they're getting 2 coins in the same hand and throwing them together. And so when that happens, you see the splash where the first coin lands. And then, because you've got incredible reflexes, the other coin is still in the air, and you can use your net to try and catch it. And the net is this big white bar you can see. You also know that the person's always aiming for about the same spot. So in this example, they're generally aiming for about the rest of the middle of the screen, but no one's aim is perfect, and so they don't always hit it. But you know that probably it's more likely than not to be towards the middle of the screen. So you're asked to put your net where you think the next coin will land. You might move it to here, which is, towards the middle of the screen, but also towards where you saw the splash. Then you see where the next coin came. And this repeats. People do a few hundred trials of this. It takes a couple of seconds to do each trial. And from that, and looking at the way people respond with where they put the net to try and catch the coin, the statistics we do can actually tell us a lot about how people are updating their expectation of where the next one will be based on what the last one did. The other task that we're doing at the moment that looks very different to this, but actually is testing a very similar thing, just in a slightly different way, is what's called a dot motion discrimination task. So in this one, people see this blank gray screen like you see here. It's got this swarm of a couple of hundred dots in the middle, and these gyrate around, kind of like seeing a swarm of flies or butterflies. But as they gyrate, they might tend to move slightly to one side or the other, as though they're being blown in the wind. And we ask people to respond with the arrow keys which way they think they're going. That's the first thing, and that's just for a start to see how well people can perceive that movement. That's really checking some baseline data rather than looking for the big difference. Where this starts to become more relevant is that once you've got the hang of that, we add in this arrow. And so the arrow, most of the time, will tell you the right answer, but not always. And so it's not reliable enough that you can just say what the arrow says, but it does give you a clue. And so when the dots are hard to figure out, the arrow should give you a clue that maybe you go with the arrow if the dots aren't obviously going the other way. And again, what maybe you can see if you sort of stand back and squint here is that this is sort of similar to what the experiment throwing coins in the lake is doing. We're setting up an expectation of what will happen with the arrow. Then we're giving you some new information when you see the dots, and we're looking at how you weight the information from the dots against what you expect from the arrow. There's a third part of this that just makes the arrow do some slightly more complicated things, but it was too hard to make slides for, and it's too hard to talk about without slides. So if you want to see that, come and do the experiment. And the last sort of big thing that I've been up to is this idea of trying to make participating in FND studies easier. And I know that a number of people here are already enrolled in this, but this comes from this sort of problem that we have as researchers. Getting people to participate in studies was too hard because participating in studies was too hard. So every one of these studies that we do, that you've heard about today, has to go through quite a painful process with the ethics committee. And so for that, we put in a big application that generally takes a couple of days to put together, telling them exactly what we're going to do, exactly how we're going to make sure it doesn't harm people, and how we're going to make sure that it's actually a worthwhile thing for people to do. And I think that the fact we have to do that is really good, but they're also extremely anal, and they'll pull you up on typos, on all kinds of other things. And the thing that they almost always say for how you can recruit people is that even if you know someone wants to do it, you can't go and ask them. You have to just put up a flyer somewhere or an advertisement and wait for people to come to you. So say I saw you in clinic yesterday and you said, please tell me the moment there's an FND study. If I have one that gets through ethical clearance and I can start with today, I can't ring you up and tell you about it. And so with this initiative we've got, FND Research Connect, this is what we're trying to get around, because this is annoying as researchers that it's hard to get people, but it's probably even more annoying as a person with FND who wants to be in research. It means that you can tell people till the cows come home that you want to do their studies, but they can't tell you, and you have to hope that you'll spot it. You have to look at multiple Facebook groups looking for flyers. You have to wander around with your eyes open, hoping that you might spot a poster somewhere. You have to hope that you've got an appointment with your neurologist at the right time that they can mention it. And so to take the effort out of both sides of this, we've set up this website and organization, FND Research Connect. And the idea of this is that what we've done is we've gone and run this through the ethics committee as a way that they're happy for people to tell us in advance that they want to be part of research, that we can then contact them directly about. So this is our website, fndresearch.org. And when you get to this, to join, there's a big Join Now button. When you first join up, there's a set of questionnaires that takes most people about 5 minutes to go through. So that asks some obvious things like how old you are and how long you've had FND, and checks that you've had FND. It also asks some more specific questions about your FND, so that, say we have a study that only wants people who have functional leg weakness, that you're not going to get lots of emails that are irrelevant to you. Because what we can do is say, here's everyone who said they've got functional leg weakness, let's contact them. On the other side of this, when researchers have a study that they want to do, they can contact us and say, this is our study, this is what we want to do, can you help us recruit? We don't give out your details, but what we do is we ask them to submit an application, hopefully not as painful as the ethics application, but that checks that it's a safe and worthwhile thing for people to be doing. So we ask them to prove that they've got clearance from an ethics committee for it. We also ask some details about their study to check that it's a scientifically reasonable thing to do and that they're not wasting people's time. And so long as that's the case, we will then send out an advertisement on their behalf to the people in our database who fit the bill for their study. Now, from that, the ball's in your court if you've got that email. You can then contact them directly to enroll in the study if you want. If you don't want to, you can delete the email and it's done. But the important thing is that they're never given any of your information until you contact them. So it's been extremely successful so far. So this is a graph I made in May last year and didn't have time to update for today. And you can see that signups from the December, 6 months before that when we started, were massive and growing. And I've just really roughly drawn on what the graph should look like now, and that we're now over 600 participants in the database. Getting it used also is something that grows over time. I've been using it. Most people who have come and done the studies I told you about before have found out about it through the FND Research Connect database. We've also just had our first 3 now studies that have been approved to recruit through this. And so they aren't recruiting yet, but in the next month or 2, I expect that people who fit the criteria for those studies will be starting to get invitations to participate. So we're really proud of this. It's big and it's useful. We'd love it to be bigger. We'd love it to be 10 times or 100 times as big, because that means that people anywhere in the world are able to find research that they want to do, or researchers can find research participants for their research. It also means that with that amount of data, we can just do that much better FND research. So we'd love anyone interested to help publicize this. So on our website here, there's this Tell People About Us tab. And this has advertising materials that have been approved by the ethics committee as being okay things to put out there. So there are posters. If you've got somewhere that you go that other people with FND might be, If your neurologist doesn't have one of these in their waiting room, you could take one and ask them to put it up. If your psychiatrist doesn't have one of these in their waiting room, same thing. If there's places you go to meet people with FND, you could put one up there. Probably more usefully, there's this social media image that's got all of our key data on it. You can download this and you can use it on Twitter, Facebook, X, Blue Sky, whatever you use. And this helps to get the word out. This helps to get more people enrolled so that we can get more FND research done. And so that's the studies and projects that I plan to spend most of the time on today. This is a rough list of the rest of what we're up to that I'll tell you briefly about, and you can ask about anything at the end that might interest you. So this first one is a project that we've done with one of our registrars who's done a phenomenal job. And this is asking a really basic but really important question. So there's this idea out there among a lot of people who know a lot about FND and who treat FND, that the longer you've had symptoms of FND, the worse your prognosis is when you have treatment. Part of that's from what they see, but actually a lot of it comes from a study that's been subtly misinterpreted over time and doesn't quite show what people think it shows. So what this other doctor we've been working with has done is to go and find every single study of treatment for FND that's been published where they said how long people had had FND. And so we're talking here about hundreds of studies. She went through all of them and got out the results and how long people had had FND for, and basically just plotted it on a graph to see what it looks like and if the response to treatment gets worse. And what we found is that the response to treatment over time gets slightly worse, but it doesn't get worse in nearly the way a lot of people think it does. And I think this is really important. And if anything, maybe it's the best possible result. It tells us that if you've had symptoms of FND for 10 years, 20 years, it's still worth treating you because you'll probably still have a reasonably good response to treatment. And certainly this is something we've seen in our FND clinic, that we don't really care about how long people have had FND because it doesn't seem to be the main thing that determines how they do. But the fact that things get a little bit worse over time does give us an argument that we can wave at hospitals, governments, things like that, to say, you need to get on and treat FND because it's easiest to do on the first day. And so hopefully that little bit of worsening gives us more of an argument at the policy level to get better funding for FND treatment. I'm going to go out of order here because maybe the thing that follows logically from that is work that we're doing in our FND clinic. So I'm the neurologist in the FND clinic on the Sunshine Coast. We've been running for just over 2 years now. We've treated over 100 patients through a full course of treatment. And from the first day, we've been asking people to fill out questionnaires about how their symptoms are and how other aspects of their health are. We do it when we put them on the wait list first, when we first see them, and when they finish treatment, then 6 months after, and then 12 months after. So this means that we can see how people do with no treatment, which is what happens from when they're put on the wait list until they see us. We can see how our treatment works, which is from when they first see us to when they finish with us. And then we can see how the treatment keeps working. And there's two things that we're particularly looking for in that 6 and 12 month period. The treatment we offer is fixed term, and by design, we're often discharging people from treatment when they still have symptoms. But what we hope we've done is that we've taught people the skills that they need to keep using to keep those symptoms improving. So we wanted to see if that happened. We also wanted to see if the opposite happened, if the people got better when they were with us, but then they just had a relapse a month later and were back at square one. So this is data that we're preparing for publication at the moment, but that shows that the treatment does help in a way that not being treated doesn't help, unsurprisingly. but then that people keep improving for at least 6 months after they're treated with us, and that they're not getting worse. So that makes us really confident in that treatment, and it makes us confident recommending it to other clinicians as something that they can do to treat FND. The other thing that we're doing in tandem with it, though, is looking at the money side, because there's clinicians around who want to treat FND, but no one will pay them to do it or give them the funding to set up clinics. And so for every person who comes through, we've been looking at the amount that the health system as a whole spends on treating them for any condition in the 6 months before they see us, then the amount that's spent in the 6 months after, and the period from 6 to 12 months after. And this is the thing that bean counters care about. You know, you can tell the CEO of a hospital that you can treat a condition that's really awful, and they'll sort of smile, but they've got a budget to balance. And what they really want to know is that you can save them money. And so what we've shown is that getting on and treating FND saves the hospital a huge amount of money. Just in the 6 months after they see us, the treatment pays off about 3 times what it costs to do. And we're just in the process of analysing the data out to a year after. And so we hope that actually, while it's not the result that we care about, it's maybe the more powerful result to put out there, because then all of these people who want to be treating FND can take that to their hospitals or politicians and say, look how much money I can save you if you let me treat people with FND. Alex mentioned the functional stroke mimic study, so I won't go over what that is. But the last one is something that I'm just embarking on now, which doesn't actually require people with FND to participate at all, but I think is a really cool way of getting information. So there are statistical techniques that have been used in cancer for a long time, where you can look at the broad population statistics of what happens with a condition, like how many people have it and what age they are when they get it. And from that data, you can work backwards so far that you can figure out things about what's happening in the body to cause it. So, for instance, how many things have to go wrong to cause it? This was first used in cancer, and from just looking at the people in the UK who got different types of cancer, they could figure out how many things in the body had to happen for cancer to start. So for some it was 6, for some it was 7. I'm just starting to do this with FND, which relates to the research I'm doing on the brain mechanisms. What from a very preliminary look I think is the case is that we should probably expect that rather than having 6 or 7 things, that there's probably only one main brain mechanism that's the difference between people who get FND and people who don't. And that, I think, is really optimistic, because it's only one thing to find and it's only one thing to treat. And at the end of all this, you know, this brain research that might seem a long way from the FND you experience, or the statistical stuff that's even further away, what I hope is that it's leading us to better FND treatments and maybe even drug treatments for FND. And so this information actually is really helpful. If we can say there's only one thing to find, then we at least know what we're looking for. And that's all I have to say, really. Watch this space. I've got a couple of other studies that are likely to start recruiting similar to the coin task or the dot task in principle. Those are going to be run online, and recruitment will be through FND Research Connect. So these are something that you can do from your own couch that will hopefully give us even more information about what's happening in the brain. If you aren't a member already, you can join FND Research Connect at fnd-research.org. Or if you've got any questions that aren't covered here, you can email me. This is the FND Research Connect email address below. Thank you.
Thanks so much. That's just been wonderful hearing about all of these research projects that are happening. There's questioned in the group, and I think some of the questions you might have answered originally. So there was a question about with that Research Connect, is it just Queensland? So it's not, you're talking about worldwide. So worldwide people can sign up. And obviously if you're doing local research things where you need people to turn up and do something on site, you just be recruiting locally, I'd imagine. Yep.
Exactly.
And what about controls through that Research Connect thing? Were you recruiting for controls as well?
Absolutely. So on the FND Research Connect website, when you click to join, it asks you whether you have FND or not. And if not, you'll just be logged as a control in our group. You know, actually, for what I'm doing now, you know, I said at the start, the thing was that we knew people with FND wanted to be in research, but it was hard for us to get in touch. Now we can get in touch so readily that for my current studies, I'm having more trouble getting enough controls. So that's wonderful in the scheme of things, but if there were more controls on FND Research Connect, there'd be more people to get in to do that.
Yeah. And what about, because there has been some research around genetic links, so say a mother has FND, are you looking for people who may be not related to someone that has FND, or say a partner of someone who's not blood related?
At the moment, I'm just taking anyone as a control. There's two sides to that, and it's hard to strike the balance. You know, if the way I'm looking at it is that if you don't have FND, then something's different about you. Maybe it's just that you haven't had a trigger yet and you will get it one day. And if there's a few of those people in the control group, so be it. There's nothing we can do about it. But it also may be that even though you've got the same genes, if it's a mother, child, sister, brother, that there's something else different about your brain that means that despite having those genes, you haven't got FND. So we're happy to take anyone.
And can you update your information? Like suppose you don't have FND now, you've gone in as a control, but then you develop FND later, or your symptoms change. So, you know, I have motor FND, but later on I develop seizures. Can you go in and update your information?
Yes. So, and up-to-date information is really important. So if you're in the database, every 4 months you're sent a prompt to do an update questionnaire. That's much quicker than the one that you do to join up. It takes most people 1 to 2 minutes, but really it's asking things like, do you still have FND? If you do, what symptoms of FND do you have at the moment? Things like that. And so we ask people to do that by sending them emails, but also if anything changes, you can go through the website and there's a link to update information through there. The one other thing, just saying that, is thankfully, a lot of people recover from FND. And those, I think, are people who might really hold the key to finding out what's happening in brains that are susceptible to FND in the long run. Because if we test people when they've got the FND, there's always this doubt, are we testing the underlying thing that predisposed them to getting FND, or are we just testing something that happens when you've got symptoms of FND? Whereas if someone's in remission from FND, they no longer have symptoms. So we can say that any difference we're seeing from controls must be the thing that predisposed them to getting FND. So if you are in the database and your FND gets better, please stay in it. Yeah, it's probably feels a lot less relevant, but actually you may be the most important group for figuring out what's going on.
Yeah, it's really interesting. We've had one question put in here about oxytocin. So someone said, Tyson has said, and Tyson, you're there if you wanted to jump in and talk to it. He's been having, what did you say, that you've had, or do injections from oxytocin help FND symptoms? Didn't you say somewhere further down? I'm having trouble scrolling. But I think he said further down that he'd had. Tyson, did you say you'd had injections for your oxytocin injections? More recently, releasing oxytocin has gotten my FND symptoms down to 0. Are there any comments related to that? Yeah, can you please speak, Tyson? You can unmute yourself, or I can unmute you. Yeah, you're unmuted now.
Hi.
Yep. Hey.
So you can see me?
Yep, we can see you and hear you.
Okay, yeah. So, well, my FND is related to my complex PTSD, firstly. And it's just chronic stress just being expressed and just having my brain all the time. The reason why I asked about the oxytocin, because I know that women during pregnancy can get injections for oxytocin. I was wondering if that had an effect in reduce that. I also know that women, when they're breastfeeding, there's oxytocin released too. Isn't that correct too? And the reason why I asked this is because last year I got to have an experience, and it took 23 years to find another person giving this experience. And basically, my pituitary gland responded to this person during copulation, flooded my brain with oxytocin, and my symptoms went to basically zero. That's what I was asking, the oxytocin effect for women in pregnancy. Yeah.
Yeah, Tyson, we don't know. Well, David can give his 2 cents as well. Short answer is we don't know yet. But it's kind of those thoughts that we had as well that were really interesting. So we thought, anecdotally, a lot of women get improvement of the symptoms during pregnancy, particularly kind of a second trimester. But as a group, we didn't see that. We thought that kind of breastfeeding, there might be some changes in symptoms as well. But as a group, we didn't see that. The trouble, I think, we see with that, first of all, I think very early days of those research projects. But I think the trouble with this, what we need to learn more and more is if we just lump people together, it pushes out a lot of the individual changes we might otherwise see. And I think to really make progress in research is doing those things, for example, that David did in the women's health study, to look at different subgroups of patients. And I think that's what we haven't done well so far. If we look at just 1,000 people and lump them all together, it doesn't help much for individual signals that, for example, what you reported there.
So looking at the difference between what causes for one person to cause, what causes FND for one person to what causes FND to another
100%,
person,
100%.
and their response. So my release from all this is all like basically the good experiences, whereas what's caused it is all those threatening toxic experiences where somebody else might have other things that cause it.
With you. And I think that's overall that kind of individual therapy, looking at more like at each person separately. Okay, what in this case are the driving factors? What are the driving forces? I think that's going to be the way forward. But clearly, that's complicated. That's really tricky to do. But I agree. That's where the money is. Yeah. David, do you have anything to add to that?
Yeah, I mean, not a lot to that specific answer. I think just in a broader sense, we have to be careful about only answering the questions that we ask. We've done a survey, or 2 surveys here, looking at what happens in pregnancy and what happens through the menstrual cycle. And I think we need to realize that that's all we've asked. Hormones change through the menstrual cycle, hormones change through pregnancy, but a lot of other stuff changes too. People are in pain, people's bodies do different things, people's brains do different things, people become sleep deprived after they have a child. And so I think from the data we have, we can't say, and we won't be able to say whether it's hormones or anything else. In the same way that when someone is stressed and it worsens their FND, we can't say, is it adrenaline, is it cortisol, is it something else about stress? In time, hopefully we'll be able to answer these, but I think at the moment, we can only say this thing, or for example, what happened to you, we can say was clearly very good, but was it the oxytocin? Was it the experience? Was it something else? Is hard to say at the moment. Maybe in the future we'll know.
Yeah, excellent. Cassie, you said you've got a few questions. Did you want to unmute yourself and ask your questions? You able to unmute, Cassie? Or you can type your questions in if you'd prefer. Let's see if that's coming. It's hard to scroll. Oh, she's not there. Okay, I thought those talks were just so incredibly interesting. I was interested in the difference sort of between the functional symptoms and when it actually becomes a disorder. So getting stuck and symptoms resolving, because a lot of times in some of the research and a lot of letters that people might get on diagnosis of FND is your prognosis is good, people get better. And I'm sort of thinking that might be, okay, people with functional symptoms, they have an onset, they might have a seizure or any other type of symptom. They often do get better, but the people that we see, certainly through our networks, are generally the people who are not getting better. So the people who are stuck in their symptoms are not resolving. So at what point do we define this as a disorder rather than a symptom?
Great question. There is not a definitive answer at the moment. The official diagnostic criteria at the moment define FND as basically as having functional symptoms which cause you distress or impairment in your function. I think that needs to change. The reason that the symptoms in healthy or in people who don't have FND paper isn't published yet is that one of my co-authors disagrees, and we're trying to find a middle ground that we can suggest. But there's so much that's not FND that comes into the functional limitation you get or the distress you get from symptoms that I think it's got its place. If I'm diagnosing FND as should I treat this or should I not, that's probably the perfect definition, because if someone's symptoms don't stop them doing anything and don't distress them, why bother treating them? But in terms of defining what FND is, I don't think that it's a good thing. In my own mind, I think that functional symptoms that are long in duration, and I'm talking probably at least more than weeks, and functional symptoms that are severe, and this probably is generally severe enough to cause some sort of impairment, although not necessarily. I think those I would pretty much always call FND. Exactly where you define the edge of that is tricky. And in truth, there's probably not a pure distinction. I don't think that what I'm looking for in my research is that there are people who are prone to FND and people who aren't. I think everyone is prone to FND in some degree, sort of across a spectrum, and that the right trigger, a strong enough trigger can probably make anyone have FND.
Yeah.
But if you're really prone to it, a much smaller trigger might be able to trigger it off.
Yeah, I'd agree.
I don't know, but watch this space.
To point out as well, these things are not unique to the neurology world. Various functional symptoms or other symptoms, flare, come and go, are common for all the symptoms we experience and in other areas. I think a good analogy for that as well, hopefully that makes sense for people, is gastrointestinal symptoms, where, most of us would have experienced a bit of diarrhea or loose bowel motion, if you think whatever your last big university exam or school exam or something, the day before or just before you walk into the exam, like, oh God, I don't feel pretty. And most people would say, oh yeah, kind of within normal range. And then you'd say, oh, if you started your last new job and you had kind of loose bowel motions or diarrhea because you're really under the pump for a few days in a row, many of us would experience those things and would still be like, oh, not much to it, kind of that comes and goes.
Stress,
But then the person who is in a new job and then has under the pump and has symptoms for weeks, months even, most of us at some point would say, oh, hang on, okay, this is not right anymore. This actually what needs treatment. So you can see with that, it's often hard to draw the line. Not unique to FND.
And it is hard, because then when we end up with sort of NDIS, it's sort of like, well, is this something mild that people get better from, or is this something really severe and disabling? And when they're so specific, it does make it hard.
And it's, I guess, with that, usually not the one who defends NDIS, because it's I'm sure we all agree, absolute dysfunctional and pain in the ass. But you can see with that, by its very nature, those things are hard to capture, hard to draw a line.
Yeah, absolutely.
I wondered if I could just chime back in to point out that, the stroke mimics study that each of us only mentioned briefly, this is part of the reason for doing that, and that we sort of see these people who turn up in ED looking like they've had a stroke with functional symptoms, they mostly seem to get better, but we didn't have any data on that. So that's what we went out to look for. And they mostly do, it turns out. So when you follow these people up, 80% of them have had their symptoms resolved by the next time you talk to them. And so what I think we're seeing there is people who are maybe on average a bit less prone to FND, who have had a really strong trigger. And, you know, it's given them functional symptoms that are not just the normal bit of tingling someone might get, but because they're lower on that predisposition to FND, their brain's eventually able to get it better. And so maybe that's an example of seeing that the stronger trigger can drive less FND prone people to get FND, but maybe they're also able to get better quicker.
Yeah. I don't know.
Yeah. With the functional stroke, and you said follow-up, what sort of follow-up time were you looking at? Because people might get better, then they might relapse.
Yeah, so good question. So this is all done using just hospital data. So we just looked at the next time someone saw them in hospital. So whether it was an outpatient clinic, they came back to ED or whatever, did they still have the symptoms then?
Okay.
But then we also looked at every hospital note for the 2 years afterwards to see if there was any sign that they'd had a relapse of functional symptoms. And I can't remember the number off the top of my head. A few had, but most people had not had relapses in that 2-year period.
And that's presenting to hospital. They could have had a relapse presenting to a GP.
Yes, but we weren't looking only for coming for an FND relapse. So, you know, when they came, we sort of went through the notes to see if there was any hint that they'd had a relapse. Okay. We will have missed some.
Yeah.
But I think we hopefully got most people who had severe symptoms, because they're not people who were used to having symptoms of FND, if you know what I mean. The second thing would probably be almost as dramatic as the first.
Yeah. Excellent. Okay, Cassie has her hand up. So Cassie, did you want to jump in and talk?
Yeah, I've just managed to work everything on my phone. Now, just a couple of questions. Thank you. I don't know about the research stuff, but is it really important with someone with FND to have a neurologist on their team?
Oh, tricky. I'll give you the shortish version of a more complex answer, and again, David can chip in. Look, I think in an ideal world, yes, but then we also all live in the real world. So, of course, in an ideal world, who is the person best trained to diagnose FND? Well, really, in most cases, that would be a neurologist. Who would be the best person to work with you to assess outcomes and assess if things change? For most cases, that would be a neurologist. But then we all live in the real world. And in the real world, as I'm sure most of you would appreciate, really hard to get in, let alone any neurologist, let alone FND interested neurologist. Waitlists are horrendous. Private people charge a lot to have their books closed, all those kind of things. So I think in reality, it's often just really hard to do. And then in reality, I think one needs to work with the resources that we have. And I would argue then in many cases, there are other specialists who probably are perfectly adequate as well. So for example, I work with many psychiatrists who, as good as any neurologist you'll see, about their knowledge of the neuroanatomy, about their knowledge about FND. They can examine a patient as well as I've seen any neurologist examine a patient and make diagnoses, particularly in certain areas. So I would, for example, argue if you have a functional movement disorder, ideally you see someone who has experience in movement disorders, like a movement disorder neurologist. But for example, someone with functional seizures, there'd be many neuropsychiatrists I work with who'd be perfectly appropriate to diagnose this. Or for movement disorders, there would be many rehab physicians who are amazing, awesome clinicians. They know their stuff. They know FND. They'd be as good as any neurologist you see in making the diagnosis. So in textbooks, yes, ideally. In theory, yes, ideally. I think in the real world, we need to have some flexibility and work with what we have.
Yeah, the reason why I've asked that, we've had neurologists and we've been discharged after a few times. The reason why I wanted to know. The other thing, you talked about the gut disorder. Now, that's come up with my daughter in the last year from the Children's Hospital. How common is that with the FND side of things, and how to sort of manage it? Because she doesn't want to eat with pain.
Yeah, that's the very reason why we do the study. Short answer is we don't know. So literally at the moment, zero data about FND and gut microbiome. We just got the grant. We're just working on the protocol. So hopefully I can tell you more in a year or so.
Yeah.
But at the moment, sorry, zero data.
Yeah.
Don't know.
And just one other, with the seizures, normally the oxygen and stuff's all normally stable. What happens, how would it class if they do drop for like a minute or so and then come back up as low as, say, 80, 88, and then go back up to the 90s?
Yeah, look, difficult to give you clinical advice. I assume that's about your daughter. Without not knowing any of the details. And David, again, chip in if you want to. I guess generally common sense, if you comfortable and clear about the diagnosis. Breath holding, for example, is not that rare as part of functional seizures, and with that, sometimes for a short period of times, oxygen levels drop. Typically, with that, then if they drop bad enough, the brainstem kicks in and the brain starts kind of emergency mode and starts breathing again. So typically, very short drops in oxygen levels are acceptable, but I know they are freaky. I know it's easy for me to say people out, but hard to give kind of specific advice for.
Okay.
But hopefully it's some help for you, Cassie.
I think you've actually seen her before, Alex.
All right, okay.
So
hopefully I've given sensible advice then.
Surname Crosby, but yes, you've seen it before.
Right.
I wondered if I could add one thing to that answer, and this is not about anything in particular, but I think it brings up a good point that people who don't work in medicine don't necessarily know, and that's that all medical tests have failings, and there's no perfect test, and there's no perfect scan, and that they all have places where they fall down. And so this is an example, I think, one of many reasons we can't give specific advice there is that we don't know what the sensor reading looked like. Those oxygen sensors, they work brilliantly in the right circumstances, but in someone who's moving a lot, where the light's wrong, there's all kinds of things that can make them misread. And so in general, for any FND, I'd be very hesitant to put much weight on a single number of anything.
Yeah. All right, so thanks for that.
Yeah, awesome. Yeah, it was some really great research. I'll be looking forward to seeing, the outcomes when you've got more papers published and ready to talk. Absolutely contact us and we'll love to hear more about them because such interesting research coming up. Does anyone else have a question they really, let me just have a look. So I can't really scroll very well on this computer, so it's hard to read these questions that are coming in. If I can, I was diagnosed. Okay, I can't scroll. But if anyone else has a pressing question that they want to ask, please speak up because I can't scroll in the chat at the moment. Otherwise, we will thank you, and thank you very much for your time and sharing those really important studies, and really, really practical studies that will make a difference to how people, experience their life, and safety with driving, pregnancy, everything. It's just incredible research. So thank you for all your time and investment into FND and making FND life better for people.
Thanks for having us. And I have to, for people are not aware, very sad to see David leave. He's moving to Canada next month after.
Yeah, we can still bring you in online for talks. We can do talks around the world.
Absolutely, but hopefully he'll come back afterwards.
I'll still be here in spirit.
Yep.
And I guess the other thing, I'll still be running experiments through University of Queensland. So if you're in FND Research Connect, we'll still be in touch that way.
Yeah, brilliant, wonderful. Yeah, we don't want to be losing all our good FND neurologists.
Can I say one thing, Kate, before we wrap up? Please, part of the reason we do these things is kind of to keep the momentum going, keep us going as a group. We all need to work together. I look at us truly kind of as the FND ambassadors, so patients with FND, family of people with FND, us with interest in FND, keep pushing it. And I appreciate it's hard for patients if you suffer with FND symptoms, but only if you guys kick up a stink will things change. David and I, we have endless battles with hospitals just to let us, I'm not even often, just to let me see patients with FND. That's how crazy it is. Unless patients kick up a stink, it will never change. So, right, health minister, local MP, push, 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 only then it will change.
Yeah, and absolutely. In terms of that, we do have in our online support group 4,600 members. In our files, there is a template there for you guys to write to ministers. It is really important to keep advocating. And Justine said something around no FND clinic in Tasmania. Where did we go? You start advocating to your state health ministers, your local MPs. We have elections coming up. Yes, Natasha, we will share the papers when they get published. We will help with that. So yeah, absolutely. We've all got to keep up our advocacy and combining forces, and that cost-effective study. They're just so important, getting those outcomes out, because we use them as part of our advocacy as well with government, is around, we need to get these clinics, these treatments happening, because, it improves the overall cost to the health system and the disability system and the welfare system. So there's win-wins everywhere. Yeah. Awesome. All right. Well, thanks everyone for your time, and thanks so much, Alex and David. It's been wonderful to hear about your research.
Pleasure. Thanks for having us.
Thank
Thanks for
you.
joining, everybody. See ya.
Hey,
Thank
bye.
you.